Everyone, and welcome to this session, which is the sponsored session by Johnson Vision. It is a symposium on the latest IOL advancements in cataract surgery, and I have with me the session is going to be divided into two parts. The first part is going to be the new revolutionary IOL that they have introduced, which is the Pure C. And the second part of the session is the, I would say at times now, the standard of care for monofocal surgery, which is the monofocal plus lens, which is their Eyhance. So this is going to be divided into two parts. Once we have the presentations on the Pure C done, we will have a discussion, and for that the speakers and the panelists for the Pure C session are Dr. Gayatri Banerjee from Sydney, Australia. Again, Dr. Tim Roberts from Australia. I think Australia is one of the countries that has the maximum experience with in the Asia Pacific region with this lens, which is the Pure C. I am Dr. Mahipal Sachdev from Delhi, Chairman Center for Sight Group of Eye Hospital, and Naren, as you all know, a great young budding anterior segment surgeon who is just finished his PhD, and as you all know, he heads the NN in Bangalore. So without much ado, we will want to start. So to begin with, I'll just set the context of the Pure C intraocular lens. So when you're looking at the Pure C intraocular lens, it's basically a lens which is filling in the void or the need that is there. What was the void or what was the need that was there was that you're wanting a lens. A patient today wants independence. From a cataract, which was restorative surgery, it has become a refractive surgery, wherein the idea is to achieve emetropia along with independence from glasses. So the evolving lifestyles of an individual, the first and the most important thing is that we have all increased the dependence on the digital devices, whether it be the smartphones or whether it be the computer, etc. So what is an intermediate vision that has changed over time, and that is a requirement for the patient. The patient wants to travel frequently, most of us drive, etc., and that is another important thing. So driving is important in international scenarios where there are long distances where people want to, and they don't want any encumbrance while driving, whether it is during the daytime conditions or during the nighttime conditions. So that is an important thing. So clear distance vision is something that the patients want. They don't want any waxy vision or any halos or glares, etc. And the reading habits have also changed. At times, the requirement for reading fine print, or if you have more difficult languages to read, for example, the Indian dialect or Sanskrit or maybe Chinese, etc., that has slightly gone down because the reading is now more, you have the pads, iPads, etc., and you want to work on that. So overall, the patient is looking towards a more active lifestyle with a focus on being able to carry on the hobbies, playing golf or also play bridge or whatever. So it's a continuous range of vision that the patients are looking. What has also happened over time is there was a survey only in 2023 by the ESCRS, and the penetration of a lens which is an EDOF lens has suddenly gone up, because though the EDOF technology was again introduced by J&J long ago in the Symphony lens, but then there were certain pitfalls. But today the EDOF is gaining a lot of prominence, and there are other companies that have also brought about it. So in today's session, let us see as to what is this new kid on the block, which is basically a refractive lens but more functioning like an EDOF lens without having the rings being shown. So that is what we are wanting to look at. This lens gives a high tolerance to refractive error. That means that if you are looking at slight myopia or hyperopia, even there is in the end stage after surgery, that should not cause you, that should not cause you, the patient, any discomfort. A dysphotopsia profile which should be equivalent to a monofocal profile. It should be far away from a bifocal or a trifocal profile, and above all, as I told you, giving you an excellent distance vision which is extended into the functional near vision. So that's the preamble that I wanted to set, and let's dive deeper into this particular lens. From the people who have had experience, we have been using this lens in India for the last 3 to 4 months. In Naren, myself and 2 more centers have been in part of a study that we'll be starting at 3 months post-op, and we shall be giving out data from the Indian scenario. But as things stand today, this lens is available commercially, and there'll be a lot of you who would have used this lens and have their own impressions on it. What is good is that simultaneously we have the lens which is available both in the toric and in the normal variety. Can I have the names of the panelists? Dr. Himanshu, is there anybody else? Virender is here. Anybody else? Huh? Himanshu, I already said Himanshu. Yeah, Ajay. So we have the panelists with us for this session. Dr. Ajay Sharma, as you all know, he heads the IQ group of hospitals. Himanshu, again a great surgeon, has the mega stars under him, and also does a lot of teaching for mental health and other activities to keep yourself busy. So this lens is going to suit you and your patients, right? So Himanshu, then I've already, Virender, as you all know, he's from Jaipur. A postgraduate from AIMS and ex-SMS, and now runs a very popular practice. So Gayatri, I've already introduced. She'll be a speaker. So she is from Sydney, Australia. Thank you. I think without much ado, we go on to the first speaker, and that is Dr. Tim Roberts, please.
Thank you. Well, welcome to our lunchtime session, and it's a pleasure to be able to share some of our experience which we've had with this lens going on to nearly 5 years. And I've worked with a lot of the companies and looked at all the different lenses, and my primary criteria is patient care. We as ophthalmologists are very fortunate that there are a lot of companies bringing extremely good products to market, and we can look at what's out there and choose what we believe is the best for our individual patient. And when we look, there's an increasing array of lenses that are now available, so it becomes a little bit tricky just exactly how we work out in our practice, how we're going to choose, what are we going to seek for an individual patient, and how we can get the best outcomes. So I'm in private practice in Sydney, which is where I do all my refractive cataract work, and then I have an academic appointment as professor at the University of Sydney, which is more teaching with monofocal lenses. And I've used all the monofocal and most of the extended depth of focus and trifocal lenses that are available. And over the last 5 years, we started using the Pure C as part of the proof of concept trial in 2020. And over the last 5 years, in my private practice, there's just been a steady growth. Over 40% now of patients are being implanted with an EDOF lens, about 5% with a trifocal, and then the others are monofocal, which we'll discuss a little bit later. Who are the patients who when you start, you probably might want to avoid a non-monofocal. So I think this is an exciting lens for those of us here in the room who might be just using monofocals, who haven't sort of thought there's a value out of the trifocal in your practice because of all the chair time and the perceived issues with dysphotopsia. So I think a discussion for competent comprehensive surgeons using monofocals, considering moving to an EDOF. So if we think what is the perfect extended depth of focus lens, well, essentially the key principle is that we maintain really good distance vision, and then it gives the progressive elongation of the focal point so that you can focus from distance through to about 1.5 diopters. So it's quite helpful at the beginning because EDOF started a little bit more as a sales and marketing term rather than a medical term. So when we were reviewing for journals, it's actually important to look technically what actually is an EDOF lens. So if we have a look, these are the definitions. First of all, you have to have statistical superiority in the mean distance corrected intermediate vision. The important thing there is distance corrected, because a lot of us as surgeons will do mini monovision with a monofocal. So if you leave your patient minus 0.75 or a diopter, they're going to get good intermediate, but that's got nothing to do with the lens you put in their eye. So you have to distance correct them, and then the intermediate and near we get is what the optics of the lens are doing. You need at least 50% of patients that you're putting them in to have a distance corrected intermediate vision of 0.2 or 6.9 or better. You need to have proven that there's at least half a diopter of a greater range of vision than a monofocal lens. And equally as important for us clinically, we need to be absolutely certain that the quality of the distance vision is not going to be inferior to our monofocal lenses. And so those are the four definitions in terms of refractive results of what's accepted now as an extended depth of focus lens. So when we have a look at all these different lenses that are available, there's lots of different technologies that different companies are using. There's diffractive, refractive, there's small aperture, there's wavefront, there's chromatic aberration, there's spherical aberration. So there's a lot of different technologies that the optic physicists are using to try and generate this extended depth of focus. So what has the Technis lens done? What have they chosen to do? So this lens is a refractive design based on the Technis platform. And what happens is that in this case they've chosen the posterior surface for manufacturing reasons, but there's a change in the elevation on the posterior surface. It's gentle, there aren't discrete changes in elevation. It gives the elongated focus, and my hope would be, because of the design of the lens, it's going to minimise unwanted visual side effects. So the initial proof of concept study was designed to compare two refractive prototypes with an enhanced monofocal. The thought of the company was that if the lens isn't statistically superior to an enhanced monofocal, there's no point putting all the commercial money and time into marketing it. So they set the bar higher by comparing the Pure C prototype to an enhanced monofocal rather than a non-enhanced monofocal. And this was a randomised controlled double-masked study, multi-centred, of which we were one of the international investigators. So just top line, what did it show? Top left, when we put the Pure C lens in, it gives absolutely equivalent distance vision to the monofocal. So the first thing that we need to have confidence as a surgeon, distance vision, tick. If you look here in the middle top, there was a statistically significant improvement in the Pure C eyes compared to the monofocal eyes, so they had much better distance vision. And if we have a look down here, this is what a depth of focus curve, this is 0.2 or 6.9, and if you drop below it, your vision's dropping out. And you can see with the enhanced monofocal and the top lines, the Pure C, the patients were getting 0.7 diopters, up to about 1.6 diopters of extended focus with the Pure C refractive lens. Another safety issue, if you will, what happens with contrast sensitivity. So we looked at low light conditions with glare and no glare, and as you can see in both of these box plots, there was no statistical difference between the quality of vision between the refractive EDOF and the monofocal. So distance vision's the same, tick. Quality of vision, contrast sensitivity is the same, tick. Improved distance vision, improved intermediate vision is better, significantly, tick. So then we had a look at the flip side is the patient's response coming back to us. And in terms of halo, starburst and glare, we can see two things. One is it was almost exactly the same as a monofocal. And the second thing is it was extremely high in terms of acceptability and low side effects. And then if we have a look down here in terms of satisfaction, again, when we're comparing For distance, exactly the same, and as we go to intermediate and near, a significant improvement in patients who were more satisfied with the quality of their vision. And this was all masked, so we didn't know what they were getting till we unmasked at 6 months. Significant improvement. And then in terms of recommendation to family and friends, which is actually a really good validated metric of an individual patient's perception of how they find the lens in their eye. Because if you ask them, how do you find it? Sometimes they don't know the words to say. It's very accurate. If you say, would you recommend this to a close friend or a loved one? It's a very good indicator of whether they're happy with what they've got. And you can see it's very, very high. So the proof of concept study was very significant, such that the company then decided to commercialise the refractive EDOF lens. And then in early 2024, it was made available in Australia with a toric version. Just as a comment, astigmatism or residual ametropia is the absolute commonest reason you don't get satisfactory results with an EDOF lens. So just the starting point for any patient is that we have to get spherical equivalent and astigmatism as tight under half a diopter as we can, otherwise the lens is going to fail. So however you treat astigmatism, please have that front of mind before you even consider using the lenses. So I put about 150 in, and these are the results of 50 bilaterally implanted patients with 6 weeks of follow-up. So if we have a look, good range of age, good range of flat to steep Ks, Ks of short eyes, long eyes, astigmatism. And you can see the mean spherical equivalent target on the Barrett is a little bit minus. This is just the current working point with the A constant from the company, where they're recommending that we choose the first minus till we individualise our A constants, because there's a slight shift to the right, which I'll show you a slide. And so that's why the target is slightly on the minus side. And then when you start, and what we did in the study was plano. As we get some more experience, these lenses do very, very well with sort of plano and minus a half in the non-dominant eye. But that's why that's minus 0.3. So if we have a look at the refractive results, the arithmetic mean just means the plus and the minus outcome, so it gets very close to zero, but it gives you the standard deviation. The absolute mean does count in plus or minus, but we're seeing for a first up trial, even the very best studies we can get are about plus or minus 0.25. So these were very acceptable results for the initial data. So as we can see, the curve slightly shift to the right, up to 1/4 to a half of a diopter, with a very acceptable number within half a diopter of the target. So what we then did with our research PhD scientist in our rooms who does all our research, we went back, we had a look at our mean arithmetic error. This is the A constant recommended by the company for the lens. What we did was, you may be aware of some of Gatinel's work, we back calculated using a theoretically reconstructed A constant. The trouble with Barrett and Gatinel, the black box, we don't know what's in it. So it's not a publicly disclosed formula, so you can't actually calculate it yourself. Some of the other formulae are publicly disclosed, so you can do the exact calculation. So unless you send all your data off to them, you have to do sort of back calculations. But when we did that back calculation, you can see with some individualisation of the A constant, the curve shifted right to the left with a very tight mean arithmetic error of almost zero. So results, what do we get in the real world doing this? The green's the corrected distance vision before surgery. So these are cataract patients, these aren't refractive lens exchanges. And the blue here is the uncorrected distance vision. And up to 60% are 6.6, and a good range of uncorrected distance vision. I then looked at, these lenses principally work bilaterally implanted. The human visual adaptation is that way. So 1 + 1 = 3, I tell all the patients. So I do try and bilaterally implant them. I've used a lot of Vivity, got very good results with it. And so when I compared the results, I'm very pleased, favourably pleased, that the percentage of uncorrected bilateral distance vision is very good, and the reported feedback from patients is very, very good that they've got crisp, clear distance vision, and we're not getting patients complaining of waxiness or problems with their vision. When we looked at bilateral post-op unaided near and at intermediate, again, as expected, the intermediate's very, very good. I would emphasise I do not tell patients this is a near reading lens. I talk about lifestyle for a computer, smartphone with the font up, but you don't want to set up expectations that they're going to be able to read small print, back of a pill bottle, lots of documents and things. If you've got a hardcore refractive patient who wants to read, if all else fails without glasses, they're going to need a trifocal. But N6 to N8 was very good. And then when we look, well, what does that actually mean in the real world? You can see here that it's really all of your average day-to-day activities that people were able to read with a good bright light. So good intermediate, and the added bonus was some near, but remember, it's not a near lens. And what we also found was that it was a tighter standard deviation, so there's more predictability compared to some of the other EDOF lenses I've used, that if you put it in across 100 patients, more of those patients are going to confidently have good lifestyle vision, spectacle independent. So what's the summary? Certainly when I compare a lens, the thing I do not want is lukewarm patients or even patients just not happy. But the feedback's been overwhelmingly positive about the quality of the vision and the lifestyle range. It's reliable and predictable compared to what you put into your algorithm, and your power calculation will be individualising A constants as we put more of these lenses in. You can do your routine biometry. If you know the Technis platform, it's exactly the same. So it's a very stress-free conversion. Minimal or no dysphotopsias, that's what I really like, that the feedback from patients is pretty much monofocal quality. So I'm a firm believer there's no free lunch. You've got to give up something, but the perceived drop in contrast sensitivity and light energy for distance certainly wasn't fed back. So I think it is going to be a game changer in my practice. I've got a higher degree of confidence now compared to other EDOFs that if I put this lens in, I would start with an otherwise healthy eye. As you get more confident and you see the results, I might find patient with mild glaucoma, not split fixation, who's had it for a while, hasn't progressed, I'll put them in. Very mild early epiretinal membranes or diabetes. But by and large, start with a healthy eye. It's my choice now, and I think for healthy eyes, I'll be up to about 50% of patients who'll be considered for a PUC. So thanks, that's our experience now over 5 years, and it's been a very positive time, and I really encourage you to have a look at this new lens. Thanks very much for your time.
Thank you very much, Dr. Tim Roberts, for an excellent exposition of what you have done over the last couple of years. And obviously from your presentation, what stands out is that this is your go-to lens as things stand today. We'll have the discussion towards the end. We now would be, he told us about using it in normal eyes, and I think we have Dr. Gayatri Banerjee from the Nepean Valley Eyes Surgeons, Australia, Sydney again. I think she's working and also experimenting it with patients with some comorbidities. So understanding the presbyopia patient outcomes with the refractive PCIOL, all yours, Dr. Gayatri.
Thanks very much. I want to approach this from the viewpoint of the user, which is us, the surgeons. And I just want to highlight some of the points. That's a new type of refractive extended depth of focus lens that offers this continuous power technology. It's on a known platform. It's a hydrophobic acrylic lens, which offers comfort to us because we know the Technis platform already. Professor Roberts already highlighted it. It really does offer refractive accuracy and a good range of vision. So it nails the distance, gives intermediate vision and some functional near for the modern day life that Professor Manipal was talking about. It also offers rotational stability and ease of delivery, which all matters to us as surgeons. Because what do we want as surgeons? Well, ultimately, we want to meet our patients' expectations. We want less chair time, simple, efficient answers. We want to meet our refractive targets with a well-tolerated lens, a known platform that gives us peace of mind. So what exactly do our patients want? Often they don't know what they want. They want a good range of vision, less dependence on spectacles, but most of our patients don't mind wearing spectacles for, fine reading, very small reading work or reading contracts, so long as they're not dependent on spectacles for everyday activities such as reading newspaper or looking on the phone. Patients don't want to be dealing with too many side effects of lenses. And although we talk to patients in counselling about the concept of trade-off, people don't really like the idea of compromise, and they want a lens that can give them as much as possible with as least trade-off as possible. Ultimately, the measure of success in my practice is that my patients want to see at least as good as their neighbour who recommended them to come and see us. So we've got to set the patient expectations about this concept of trade-off. Clarity is very important, nailing the distance vision, as we mentioned, range of vision, and side effects. And the PureC offers this refracted extended depth of focus technology with this continuous change in power on the posterior surface. And that actually allows a distribution of light from far to near, which allows a greater range of vision. The other key factor is that it's not too much compromise in terms of dysphotopsia. And the dysphotopsia profile is very similar to a monofocal. If you compare multifocals, there's a significant trade-off to be had. The dysphotopsias are forgiving even under the condition of defocus. And so with a plus 0.5 diopter hyperopic error, they still have less dysphotopsias compared to a trifocal or a symphony, and again with a minus 0.5 diopter. An important point is the corrected distance vision, and a point about this lens is that you must use the maximum plus technique, and auto-refraction is not enough because that just uses the central zone to estimate the refraction. So you need to instruct your staff, measure uncorrected distance vision, and then start at plus 0.75 diopters and drop down in minus 0.25 diopter increments to get the best corrected distance vision. The delivery system is our known platform, Simplicity platform, that's preloaded, 3-step process: hydrate, advance, and deliver. And it's easy to insert during surgery, and you don't have to worry about nurses scratching lenses, etc. The rotational stability is achieved with the haptic design, which are squared off and frosted. And in my own real-world experience, I've had no requirement for intraocular lens rotations post-operatively with this lens. My own experience of 91 eyes over a 6-month period, it was a retrospective, non-randomized study in a real-life clinic. We did not exclude mild comorbidities, and we achieved 91% of patients achieving 6 on 7.5 or better for uncorrected distance vision, and 100% of patients achieving 6/9 or better. Intermediate vision, 78% achieved N8 or better. And again, near vision is not promised, but it does provide functional near. We can see the depth of focus. I use aberrometry post-operatively, and can see that it does offer a greater depth of focus compared to a monofocal. I was a heavy user of another non-diffractive extended depth of focus lens, and my impression is that it actually provides that depth of focus without these complaints of halos and glare. And I am a user of mini monovision, and one can see on the PureC image, we can achieve a great range of vision. At this particular patient had a range of 5 diopters with the use of mini monovision in the dominant and non-dominant eye. So it's increasingly taking up the bulk of my practice, becoming the default option. Monofocal lenses are still an important choice for patients, particularly if they've got other severe ocular pathology, ocular surface issues. High myopes, there's still a role, I think, for keeping them myopic. Multifocal lenses are for the patient who's really highly motivated for reading vision and is prepared for the trade-offs. And also, it's a lens in my practice of exclusion. You have to exclude if there's strabismus, large pupils, retinal pathology, severe dry eye, high-angle kappa. The most important exclusion is the personality of the patient, who's got to be able to prepare to accept the glare and halo. So, some real-life studies. This was a fit 65-year-old gentleman who is a company director, is a keen golfer. He presented with a rapid deterioration in vision, no significant ophthalmic history that he knew about. He presented with a vision of 6 on 9.6 and 6 on 24. And I found on the initial slit lamp examination, he had a significant dry eye with a tear film breakup time of 5 seconds. I treated him with lubricants and hot compresses. I brought him back 6 weeks later. Interestingly, his vision had actually improved to 612, just with that alone. And we then proceeded to recheck biometry and proceed to cataract surgery. The outcome was the patient was delighted. He was not noticing halos and glare. His best corrected distance vision was 6 on 4.8 in the right eye and 6.6 in the left eye. Intermediate, 6.12 in the right, 6 on 9.5 in the left. And he can now see his golf ball. So he's a happy patient. Given this early experience, I then started to move on to use this in patients with a wider range of issues. This was an 87-year-old gentleman who initially presented in 2021. He had shallow anterior chambers and cataract, vision of 6 on 48. At the time, I initially performed peripheral iridotomies. I then proceeded to cataract surgery with the iHance intraocular lens implant using the Hoffer Q formula because he was noted to have a short axial length. Postoperatively, he achieved 6 on 7.5. He could read N12. He was happy, but he thought his near vision could be better. In 2024, he presented with his second eye. Vision had reduced to 618. By then, for shorter eyes, I was using the ESCRS multi-formula, and I ended up using the Kane formula for this patient. Postoperatively, he achieved 6.6 unaided and N6 unaided. So he's a very happy patient. Third case, and this is again after achieving a little bit of experience with the lens. It's a patient who had pre-existing pathology, initially presented with proliferative retinopathy and diabetic maculopathy and significant dry eye. So I treated all of the above with anti-VEGF injections, panretinal photocoagulation, lubricants, and IPL. So once all of this was stabilized, we then proceeded to the PureC lens implant. Postoperatively, the patient sees 6.6 and N8 for near. So this is a user-friendly, reliable lens with less trade-off, suitable for a wide range of patients, and delivers a practical range of vision for patients in the real world in a general clinic. Thank you.
Thank you, Dr. Gayatri, for giving the clinical overview about the PureC lens, the pure refractive lens. And now I invite Dr. Naren Shetty, and he is a very good surgeon, excellent surgeon for phaco, LASIK, SMILE and all other things, and he has completed his PhD also. Let us hear from him his experience with the pure refractive lens in India. Over to you, Dr. Naren.
Good afternoon, everyone. On this onset, I would like to thank J&J for giving me this opportunity. These are my financial disclosures. Now, let's dive in directly to our clinics. What is a situation where we choose a non-diffractive EDOF over a trifocal or a diffractive or a diffractive IOL? It is situations where either the eye is a non-pristine eye, where already there's some problem going on in the eye and you don't want to compromise in quality. The second thing is where patient already is wanting no glare, no halos, and he's very concerned about his visual quality. So just to summarize, he wants the best quality vision, but he wants a presbyopic option, right? When you're talking about best quality, this is where the POC really comes into picture. It is a purely refractive. When you look at the surface of the lens, you can't make out the difference. And forget about the rings, you don't even have any bumps on the surface. And when you look at all the publications currently on this particular lens, it's comparing to a monofocal. Why? That is the quality of quality it's actually delivering. It's very comparable to a monofocal IOL. So this is our experience with the POC. We have done over 60 cases. But before I share that, we need to understand one concept, something called as, see, these EDOFs have something called as landing zone. And when I say landing zone, that means anywhere if my power falls between plus 0.5 to minus 0.5, I will still have 20/20 vision. Now the question is, how do I refract this patient? If I refract it to 0, it's 20/20. If I leave a little plus 0.5, it's 20/20. So I don't know what to do, right? So we have to remember this concept as maximum plus refraction in these patients. So that means we are trying to push the defocus as much as possible so that we explore or exploit the entire potential of the lens. So basically when you maximize it, you shift it, you can see this, you can shift it. So automatically your near and intermediate improves. So whenever you refract EDOF IOLs, just keep that in mind, maximum plus. So anyway, this is our 3 months post-op data. And at that point, actually, there was no toric lenses. Even so, if you look at the unaided vision, 90% of the patients were 6/6 or better bilaterally, and 100% of the patients were 6 by 7.5 or better. So, which shows that how much tolerance it has to residual error, even though we didn't use any toric lens. Next is, this is best corrected distance vision, monocular vision. About 5% of the eyes had some amount of amblyopia. But if you look at the same set of patients, binocularly, 100% of the patients were 6/6 or better, and 31.6% of the patients were 6 by 5. See how beautiful the binocular vision is, even though the 5% of the eyes had some amount of amblyopia. Now, when we come to intermediate vision, 57.9% of the patients had 6 by 7.5 or better, and less than 6.9, about 100% of the patients were performing really good in terms of the intermediate. When we come to near, 100% of the patients were N8 or less, and 57.9 again were N6 for near. So they did really well at different distances, and this is how the defocus curve is. And it's very similar to Symphony, but near vision a little bit better than the Symphony, but none of those side effects which Symphony had. Anyway, in terms of the quality, the point spread functions, MTF does really well. We have got the median of MTF value of 0.33, which is better than any other EDOFs right now in the market. And when we look at the visual quality questionnaire, it is very similar to that of a monofocal. As already mentioned, we also had a similar kind of results. And I want to share my first 2 cases of the POC. All right. So this is a 70-year-old male patient who was very keen on a presbyopic option, but he was very, very particular that he wanted good quality too. And again, here we went ahead with the first minus, that is minus 0.33 in one eye and minus 0.38 in the other eye. So when we look at the results, the distance uncorrected vision were 20/20 for both eyes. The distance corrected vision were bilaterally was 20/16. Intermediate unaided was 20/25. Distance corrected intermediate was 20/20. And the near vision, both uncorrected and distance corrected vision is innate. When I say distance corrected, again, please remember that is the maximum plus. So visual quality, you can see how good the MTF value is, and also the point spread function, it's fantastic. This is case 2, again, a businessman who was, actually used to drive a lot, so he was very concerned that he didn't want too much glare halos, but wanted good quality vision for intermediate and near 2. And here again, we went ahead with minus basically the first minus, that is minus 0.34 in one eye, the other eye was minus 0.29. And here you can see the patient was uncorrected 20/20 for both eyes, distance corrected was 20/20. For intermediate, uncorrected and distance corrected were 20/20, and even the near was uncorrected and distance corrected was N6. Basically, patient was perfect at all distances. Again, excellent visual quality too. But enough of all this now. When we talk about presbyopic IOLs, we have so many lenses in the market. It becomes really challenging. Forget about patients. We doctors itself to understand and explain all this becomes practically impossible. So this is how I divide my lenses into diffractive and a non-diffractive. Keeps it so much more simpler, and it's easier to counsel the patient. Now, but how do we choose which eye we choose a diffractive and which eye we choose a non-diffractive? This is how my decision tree is. So if a patient wants a presbyopic option, first I see if the patient is suitable for a diffractive IOL. And this is a simple criteria which we follow. And if the patient is suitable for a diffractive IOL and a patient is not a type A personality or not a negative character, then we go ahead with a diffractive IOL like Synergy or any other diffractive IOL. But if the patient is a type A or a very negative personality, then you push towards a non-diffractive IOL like the PureC, which is, as you know, as you've seen the data from all three speakers, it behaves so much like a monofocal. Now, if it's not suitable for a diffractive IOL, you can either regularize the cornea so that it becomes more regular, and then you can go with the diffractive, or you don't do anything, just go ahead with a non-diffractive. So this is a simple decision tree which really helps you to decide which patient gets what, and the patient also is easy to comprehend too. Now, if we are one of the people who haven't started presbyopic IOL and we want to start something, then PureC is the lens for it, because to do a workup for this lens is just like how you do a normal workup with a monofocal. It behaves like that. And the dysphotosphere profile also is very similar to a monofocal. And plus, you don't need to look at all these parameters, pupil size and high order aberrations and motive. All these things you don't need to look at. So it's a very easy lens. You can actually start off today itself. If you're implanting monofocal, this is something that you can easily change over, and it's a very forgiving lens, and believe me, patients are always happy. And then I would like to invite everyone for our conference in 2025, July 18th and 20th in Bangalore. This is one, it's a single place where you can get anything and everything about cataract refractive, from your wet labs. You can actually do your lenticular procedures, everything. It's all in one roof. Thank you so much for your time.
Thank you. Thank you so much, Naren, for the presentation. We now throw this open for discussion. I think, let me just see, how many in the audience have had experience with the PureC lens? Can you raise your hands? Okay, so there are more people who are uninitiated on that. Dr. Roberts, are there today, after you have worked in it for so many years, are there any relative contraindications that you would say? Once you said that this is how you should start, but my question is, are there any patients where you would say a no-no for going in for the PureC?
I think the patients are going to pay more for this lens, and so anatomically, if they have reasons in their eye where they're not going to see well, you've just got to make a decision. So if they've got diabetic macular edema, if they've got a corneal herpetic or traumatic scar, what have you, you've just got to work out if the patient's going to pay more for the optics in a lens that's going to give them some lifestyle, but the rest of their eye's not going to provide that, then I think you just have to work out what's in the best interest of your patient. I've had a couple of patients who I've fully explained that I don't think they're going to get the value because of their eyes and they want to go ahead. I don't think you're going to do any harm. The only thing is, once you go to any lens that isn't a monofocal, you're reducing the light energy going into the eye. So particularly retinal and macular disease, you just might have to have your sort of first do no harm hat on and think this macula needs as much light energy for the rest of this patient's life. But broadly speaking, anywhere where the eye anatomically is not going to see as well as it should, you have to justify, I think, using a lens that they're paying more for and is more complex when you might not get that outcome.
Okay, thank you. Just moving on to Himanshu, you tried this lens. What are your early experiences with it?
Yeah, I have tried this lens. I'm very happy with it. In fact, I would just like the audience, if you were to get yourself operated, which lens would you like to use? I'm going to give you some simple ones. Simple, good old monofocal lens. The extended, how many of you for monofocal? Interesting. The percentage has reduced now. Earlier it used to be a huge percentage for monofocal. Extended depth monofocal. How many of you would want?
That's the top one.
That's interesting. And how many for multifocal or a trifocal?
Nobody.
I think we should have asked before.
This is biased because the others did not raise their hand. A lot of people did not raise their hand. How many of you want to get rid of your glasses anyway? Everybody wants to get rid of our glasses. Then why are you so biased against multifocal? Anyway, so the point is same station. And on the dais, I would just ask the dais, if you have a lens to be implanted in your eye, which lens would you choose? Sonu, this is important that...
So I think for me, PureC has really been a game changer. And for me, I believe PureC is the lens in to go, because bilateral implants have really done wonders and the patients are very happy for both distance, intermediate and near. Hardly any glare, halo and those photooptic symptoms. So I think that's the lens of my choice now.
Dr. Agarwal?
Yeah, until PureC came, I actually wanted for synergy, but with the experience of the PureC lenses and the happiness I see in the patient and the working of the PureC that is giving good distance, near and intermediate vision, I think PureC scores over the synergy. But definitely the people who are against about the multifocality, I think you are more afraid than actual. And multifocality, particularly with the synergy, gives you very good vision and satisfaction also.
So Virender, you made a statement regarding near also. So do you this is different from what Dr. Robert said, that he normally tells the patient it's a lifestyle lens which will give you good intermediate vision. So do you do anything extra like a mini monovision or something like that to tell the patient that this is also for near, or you don't tell them that it's for near? What's your kind of narrative that you give to the patient? What will this lens do?
So with the one eye, I say print media may be difficult. The reading on the newspaper or something may be difficult. But my aim is that try to keep him on the minus 0.25 plus. Means more than 0.25 should be the first eye, and if he is not happy with the first eye, then you go for 0.5 kind of thing for the other eye. So micro monovision kind of thing may be required for PureC. I have done almost 42 eyes, 42 lenses, 8 are bilateral, rest are unilateral, but with the unilateral lenses also, they are reading newspaper and they are doing distance, intermediate, all work.
So, in my experience, I feel that with the bilateral implants, once the patients are using their mobiles, a little increase in the intensity and the size. I think they are very, very comfortable doing with their own mobile. And as rightly said by Dr. Virender, we would just counsel them that whenever you need a print, you might use an ad.
Yeah, so basically that means that your patients would, at least the patients that I have worked on, the ad requirement for reading medicines or whatever, so it's about a +1. I don't know what. Dr. Gayatri, Tim, what do you want to say?
Can I make two comments? One is patients have absolutely no idea what intermediate and near means. I never use that language. That's our reporting, our medical journal language. Patients talk about using their phone, they talk about using the computer, they talk about their tablet, whatever job they have. And so I craft the entire discussion around their lifestyle. So I'll say, you might be able to see a magazine there, you'll see your computer, you'll do this. If they say, well, I do a lot of sewing and I do some fine woodworking, I'll say, well, you're not going to get that with this lens. You'll need, a pair of magnifiers for that. So we talk about intermediate and near when we're talking about the published results, but can I encourage everyone, patients have no idea. So it's all about their lifestyle. So if patients are wanting to read back of their pill bottles, they're diabetic, they're this and they're that, and if you set them up to think they're going to get that, they're not going to get it. So I would use real world lifestyle vision. The other thing to the question is what lens you'd have. We get this a lot at lots of conferences. Can I suggest it's a far better question to phrase it, if you could get a lens in your eye, what one would you want? So for instance, I'm 6'5", bilaterally emmetropic, incredibly type A, and the tiniest little thing would drive me mad. I would love to have probably a non-monofocal lens, but maybe I shouldn't. So I think the question more would be, if you were suitable, what lens would you like? Is just a far more useful question, because I'd have two different answers. If you were counselling me...
So what's your answer?
Well, I think you would say you're a lovely person, you're incredibly type A, you see the tiniest little thing's going to drive you nuts. We painted a wall, I saw a little crack there, it drove me nuts, my wife didn't notice it. So I think I may not be a good candidate for something that isn't. I tried a contact lens consulting for blended vision and I got seasick. So, I've lucked out. I'd love this technology, it may not be the best for me. So I think that's a better question. Don't be embarrassed if you're not the right person for it, is what I'm just trying to say. Doesn't mean I wouldn't put it in 100% of patients who it's the best lens for them.
Naren, you wanted to say something?
Yes, sir.
Is it an N6 lens, or you consider to be the safer side an N8 lens?
Yes, I would really say counseling is everything, and what we tell to our patients is very important. Even if it is a diffractive IOL, please don't ever say you'll never require glasses. That means you have dug your grave. So please don't do that. Always tell these words. Let's say if it's a diffractive IOL, you can say, look, most of the time you won't require glasses. But let's say if it is a very bad situation, very bad lighting, very tiny letters, in those also you might require glasses. Step one. Step two is, if you're talking about a non-diffractive EDOF, in such lenses, what you need to say is, you might require some tiny glasses for reading purpose. Just keep that. Always, it's good to under promise and always over develop. And in these lenses, most of the time, even actually you don't need to, because when you do the first eye and patient's already reading really good, then you just target the same first minus and be done with it. But if not, then you can just bump up the next minus and the patient does fantastic. And this is something that we have been always doing over the years with non-diffractive videos. I'm sure all of you must have used. But the only difference here is the quality of vision in this lens is far better than any other refractive EDOFs currently. So that's the bump up you get. So that's what the patient really appreciates, in terms of the driving and other things. What happens in a regular monofocal or whatever, you can get a little bit of glare and halos in a monofocal. Very similar kind of pictures here also. So I would say this is how if we counsel, we'll have very, very happy patients.
Thanks. You wanted to say something, Gayatri?
Yeah, I just wanted to emphasize the golden opportunity that we have between the first eye and second eye. And that's the time when it's very important to talk to the patient and make sure that they're happy with what they've got. And if they're happy with their reading vision, that's great. You could maybe match it for the second eye to try for binocularity. That might please somebody like Tim, who's going to need binocularity to get best quality vision. But if a patient says, yes, I'm happy, but I'd like to just read the paper a little bit better, that might be the opportunity to bring up the option of monovision.
Great. Dr. Narang, you wanted to say something?
Yeah, Dr. Himanshu conducted a quiz just now. what lens you want to have. Everybody said pure C. Why not other EDOFs?
Okay, that was my next question. Anybody on the panel here
so-
has experience
so,
with one eye or different EDOF, and you put this into that other
I
eye?
think, so we have, I mean, I personally haven't combined the two currently because in India at least it's recently launched and still we need to, I mean, we are at certain protocol studies which is going on. But the point is, you can mix and match. There's no problem. Personally, I don't do it, but if you compare with other EDOFs, again, the studies have already shown that it performs better in quality. And actually, I think last in Bombay, Dr. Black, right? I mean, yeah. So he's done a lot of comparison directly with Vivity and Vivity IOL and the PureC. And he's shown that in most of the studies, in terms of the quality of vision is far superior. And that is something that I think, has it been published or he's yet to publish the data? It's published? Yeah. So it's already published. That is something that you can also look at.
So,
I'll try to.
so Dr.
give some
Narang,
answer.
just to add to what he has said,
Yes.
I took the liberty, there was a patient who came from Mumbai. He had one eye, the other EDOF that Naren just talked about it. He wasn't terribly happy with it, though he was, but operated at the same, not by you, operated at the same hospital where Shah Rukh Khan was operated. Anyway, so he came to me and he was relatively uneasy, and this lens had just been launched, and I said, okay, I'll give you another lens, and I gave him a Pure C. So his answer, one line was, it is a difference between day and night. That's the answer that he gave me, that this is day and night. The quality of vision that I have in this is, and he was happy for 1.5, 2 months. He didn't want, then he said that for fine, I need something, so I've just given a 0.75 ad. That's about it. So that's my limited one patient experience, day and night.
So even if you just look at the lens itself, it's very simple. I mean, if you don't look at anything that is smooth, always we have a tendency to be delivering much better quality of vision, and that is what is being done by the POC, and that's something that all of us who have used it have observed. The quality is the one which is coming very, very close to a monofocal. Yeah.
So I'll tell you two experiences. One is one patient bilaterally with one EDOF, not what you mentioned. 6x6, bilateral 6x6 for distance, and with 0.5 and 4.5. Very happy patient. So, but on the other side, I have one more patient in the waiting hall who has both the eyes Pure C, and he has a +1 ad. Same result, 6x6 and 6. But the Pure C, both are young patients, young means relatively younger, and they are comparing notes. And this guy, Pure C guy, is very happy with the result. They are comparing the TV on the wall and watching, and then the dysphotopsia part and the photic phenomena part was more in the other EDOF, which is very popular EDOF, not the one you mentioning.
Give the name. That's a quiz, huh? Your quiz. Okay.
And then other experience, which Johnson people will not like. The one patient I put very, very type A, as you mentioned, type person. My mistake. Probably my counseling was not correct. We put synergy in one eye. Synergy. And patient was absolutely upset. All those 6x6 and 5 uncorrected in that eye. And again, when she was sitting in the audience, in the waiting hall, she compared notes with another person who had Pure C. And in the second eye, although I don't know whether it was the right decision or not, I put Pure C. She wanted Pure C. And the other eye photic phenomena is also gone now. She is very happy with the combination.
So definitely the thing is that you can combine the two, because this is not, there's nothing wrong with it, because the combination, not like this now current generation of diffractive IOLs are far superior than the older generation bifocal ones. And in the older generation bifocal ones, they used to combine a monofocal and bifocal eye, and many publications, and they do very well. And definitely, if a situation comes like this, you can do, and they do very well. And it just bilaterally, when you open, they just compensate everything, and patients very, very happy. Yeah.
So I think there are a couple of powerful statements that Dr. Narang made. One is that despite refractive error, it's far more forgiving from a patient satisfaction point of view. The second is that it will take away the dysphotopsias from the other eye. And the third is never go to Dr. Narang's clinic, because he has microphones sitting there where he can record what the patients are talking with each other, right?
So it takes off the dysphotopsia from the other eye, but adds dysphotopsia to the next patient.
So anyway,
Two
I
things
think
still are pending. When we
Abhi
had
or?
Dr. Shetty yesterday, so this is forgiving as far as the angle alpha is concerned. This lens is forgiving.
Yeah.
And one more thing you were mentioning. And squeeze is still open, which was other lens where ad was 0.5, but he was not as happy as Pure C.
So anyway, I think any last comments on that? But you want to say any
I
last?
just wanted to say that I have been mixing with the same platform. So I showed the case where I put an iHance in one eye and the Pure C in the other. And I actually do have one case who I put a Vivity in one and a Pure C in the other. And anecdotally, the reason they weren't, I chose that is because of the halos and glare. Particularly in Australia, we have patients who do night driving for long distances. And I do find that patients with that lens tend to notice halos and glare.
Yep.
Yeah, you can. I just wouldn't. Why would you? You've got a new state-of-the-art, cutting-edge technology lens. Why would you put an older generation lens in the other eye? So I think if the patient presents with one, you may choose to provide a better lens. But to me, I would just put bilateral, if you're going to, bilateral Pure Cs. And just a final comment, one that I've found so helpful with these patients is to move away from the sense of patient happiness is binary in the sense of using a spectacle, because some patients get the impression if they use a pair of glasses for jewellery or woodworking or some activity, it's a failure because I'm not spectacle free. So it's really helpful to set up with your patients that happiness does not mean 100% absence of spectacles. Happiness means a really happy lifestyle. For most of your day, 90%, 95% of your week, you're incredibly happy. And then when you're sitting at night knitting or sewing or woodworking and you put lightweight magnifiers on, that's a happy outcome as well. So I think it's really helpful to break the connection between happiness and a binary all or nothing, no glasses or glasses, because you just create unnecessary angst.
So we should shift from the GDP to the gross happiness index, which is the highest in Bhutan, right?
But
I think
Maipal,
the
just
question can be like this: when you have a lens with the different zones or a diffraction, they can have a good quantity of vision, but the quality of vision may be a compromise. With the monofocal eye concept of refractive lens or with the continuity, the quality is better. So what patient is appreciating is the quality, and different conditions may have a different quantity and different quality. So when you do bilateral implants, the patient's quality improves over it and gives you happiness and
So
satisfaction.
last quick comment, 20 seconds.
So one thing is certain, his patient was happy with the other eye Pure C because the other eye they could read. Remember, most of our patients wants to see their WhatsApp by evening or next day. And what he said was very correct, that lifestyle, they're not going to see near, they need glasses. Whatever and how much you tell your patients that you'll need glasses, whatever you do, they still want to read without glasses. That's one thing that I would depart with.
Good.
So you might want micro-evaluation.
Naren, thanks. Well, I wish to thank all the speakers here and a powerful discussion on Pure C. My 2 cents are that those about 50% of the doctors here who have not used Pure C should step out and use that. I think you will have a good, pleasant experience with this. And thank you very much, all the speakers and panelists. And may I request Dr. Ramamurthy to come to chair the next session, and that next session is going to be on mainly on eye hands. Ram, would you? Yours is the first talk, I think. So, friends, this is a tested lens which I don't know how many lakhs. We have to take a picture. Just 1 second. Ram, you can set up. Yeah, Himanshu. Yeah, Ram. Ram, you can.
Yeah.
Yeah.
Good afternoon, friends. I think that was a very interesting session on the POC. Oh.
Thank you.
And let's now briefly discuss what's already been available to us. And may I call my fellow panelists. The speakers are Dr. Jeevan Singh Tityal, Dr. Mahipal Sachdev, panelists Dr. Arup Bhaumik, Dr. Rupakumar Reddy, Dr. Piyush Kapoor, Dr. S.K. Narang, Dr. Vineet Ratra. Please join me here. So, basically, this is, as was being said, this is a time-tested platform and we have had significant experience. But does it really do what it claims to do? POC is a reasonably newly introduced lens and we are all gaining initial experience with that. But unlike that, the iHands has come to stay and has become a game changer. Basically, many of us are shifting over completely from monofocals to iHands. And does it justify this kind of confidence? And this is what we are going to see in this half of the session. Initially, I'm going to be giving an introduction about this lens, rather a review of literature that's available.
Thank you very much, Dr. Ramamurthy. As you all know, he's been the past chairman scientific committee and past president of AIOS, runs a great eye foundation and really one of the giants in ophthalmology in India and overseas. Dr. Ram.
Thank you so much, Mahipal. My topic is elevating cataract surgery standard of care with a game-changing intraocular lens. This is going to be a very short literature review. No financial disclosures relevant to this presentation. Though we keep talking about multifocal, trifocal, what lens you will have in your eye, toric lenses, etc., one lens that has remained constant is the monofocal intraocular lenses. And very little has happened as far as the advancement of these lenses is concerned in the few years. In 1995, from PMA, we got the foldable lenses, asphericity in the year 2001. The haptic design, we went on to the single-piece lenses. The yellow pigment with doubtful advantages was introduced. PCO prevention by square modification of the edge of the lens came into being. But then I think the incremental benefit was really introduced by the enhanced monofocal concept, which the iHands brought in. And this was a paradigm shift as far as monofocal lenses are concerned. This is, of course, built on the time-tested millions of lenses that have been implanted more than 2 decades of the Technis platform. And when you are talking about the iHands, it's not the near vision that we are talking about, but it's the intermediate vision that's of concern. It essentially gives you good distance vision without any drop in quality, good intermediate vision, and then functional near vision. So, and once you get this, a 60 or a 70-year-old is almost able to do most of their activities, day-to-day activities, without having to rely on glasses. We always tell these patients that if you want to do significant amount of reading, you would require readers, and we are not even doing much of monovision these lenses. And once you set these expectations right, it seems to work well. I think it's been said that the imitation is the sincerest form of flattery, and just the number of monofocal plus lenses that have become available in the market, just because the other part of the industry also felt this is a good way to go, is that's the reason you have a flurry of monofocal plus lenses, and obviously it's a good thing to have. And I'm going to just very briefly review the literature, just about 3 or 4 slides. Basically, it's a holistic view of all the published literature on the Technis iHands and other enhanced monofocal, with the objective to empower our evidence-based adoption. Almost, I'm sure everyone in this hall is using iHands and has some experience with this. But is that the right way to follow? The search date was on 4th of November 2024. The search platform was on PubMed and Embase, and iHands and other other monofocal plus lenses were essentially used for the search, and the conference and podium abstracts were excluded from this particular research. As you all know, that systematic review and meta-analysis and the randomized control trials have the greatest evidence, while on the hierarchy of evidence, expert opinion has the least. All this was taken into consideration, and what you see over here is that the Technics IHANS has the largest body of evidence regardless of study design or evidence level. The number of as far as the literature evidence is concerned, the number of published paper, peer-reviewed published papers is almost double of what has been published, all the other lenses, the monofocal plus lenses put together. And the level 1A evidence is systematic review and meta-analysis. There are 3 published papers. Level 1B, that's randomized control trials, is 10 published papers. And out of the 51 IHAND studies, 48 focus on intermediate vision and demonstrate a significant amount in 98% of these studies. That's essentially the selling point or the claim of this lens, that it's a good intermediate vision, and that it truly seems to function that way. And another important aspect is that when it's compared with any monofocal lens, irrespective, not just the Technics one, but any monofocal lens, that there is a consistent result in the improved intermediate vision, regardless of the conventional monofocal lens that is checked with. These 2 slides are the representative of all the monofocal lenses that have been checked. It has been compared with. And how does it line up when you compare it with other monofocal plus lenses? Even though as far as the performance and improvement in the intermediate visual acuity is concerned, they may be performing similarly, there was a demonstrable superior quality of vision as far as in terms of the contrast sensitivity. So essentially, and this is just in case you are interested, this is all the literature that you can go through on these monofocal plus lenses. So POC is something that we are just gaining experience, at least in India. But as far as IHANS is concerned, it has a significant history, and all of us have adapted to us. In the next couple of speakers, based on the evidence that I presented to you before, they are going to talk to us about their personal experience. Over to you, Mahipal, to take up your topic. And I don't think I need to introduce Mahipal. He has already been doing a great job and leading the Center for Sight with its huge number of branches, and also at the cutting edge of technology at every aspect of anterior segment surgery.
Thank you very much, Ram, for the kind introduction. I'll be talking about the monofocal plus lens, as it is now called, over the conventional monofocal lenses. The current monofocal lenses, as you all know, it has its limitation. The obvious advantage is that 100% of the light is used in a monofocal lens to come to a particular focus. But when you look at the quality of vision as it, or the quantity even of the vision, as you go on to the intermediate or the near, it tends to fall dramatically. Some patients who may be having some with the rule astigmatism in the cornea, etc., may have some intermediate vision, but by far distance vision quality is excellent, and the intermediate and near tends to fall down. Now, what are the known demerits of the bifocal? First of all, you got the bifocal lenses, you got the diffractive, you got the refractive version, etc. So if you compare with the bi or the multi or the trifocal lenses which are there, the first and the foremost thing that happens is that you are splitting light. As and when you split light, you are not using 100% of the light for the same point focus, and therefore there are going to be problems, especially in dim light and when the contrast is poor at that particular point, which is for us, it is absolutely critical even for operating surgeons. When you go on to the other part, which at times can be rather harassing for you, because the patient can be after your life, there can be a lot of brain damage that the patient does if the patient is not able to get out of the dysphotopsias, that is the glare and the halos that he has. IOL exchange is often heard of when we have done, patient is not adapting to it, and specifically the adaptations are very less forgiving if there is a residual refractive power or there is a toricity, there is a problem. Now, as even in my practice, I have not had to explant a single monofocal plus IOL ever since I have introduced, because the problem of dysphotopsias, glare, etc. I don't know anybody in the audience if they had needed to explant this monofocal plus IOL. Now, so this is just a comparison of what I have said, that EDOF monofocal and trifocal, the main problems that come here is the dysphotopsias that you have, the patient satisfaction is much lower, but when you have a monofocal plus, you have no dysphotopsias, unaided intermediate vision is good, and the patient satisfaction is good. So as we have transformed our life, unfortunately, we have become potato couches. We are not doing a lot of outdoor activities which used to be there, and going out with friends, etc. You are now slaves of the computer, the near work, you Google Maps, etc., etc. So this is what life is all about now today. So this is intermediate vision, and this is what we are looking at. So therefore, the need for having an active lifestyle is to have distance vision clarity, as also good intermediate vision. That is the important thing. Near vision, the concepts have changed. You don't do like many fine reading, etc. that is there. So the IOS lens, which is my go-to lens, we were just looking at our numbers. So we have used about 14,000 plus IOS lens in the last fiscal. So that's a big quantity of the lenses that we use, and that's our go-to lens today. So the first thing is no rings. If there are no rings, you will not have the problem of dysphotopsias, glare, etc. It is based on a continuous higher order aspheric surface. The surface in the central part is so modified that this is an aspheric surface, and it is visually indistinguishable. If you see it under the microscope, if you are implanting from a Technis 1 platform has been with you for ages, and it's been a fantastic lens with no glistening and great clarity for distance vision. So it also, as you know, is an aspheric lens like the Technis, and it tries to reduce the spherical aberration to near zero. Now this is how it looks. If you look at a Technis 1, you will see that it is the same, but this is this small little bump that is there, which is the zonal design. There is no abrupt change in power. So since there is no abrupt change in power, there is no dysphotopsia, no glare, etc. The periphery of the lens is absolutely identical to what the Technis 1 is, and the power is increasing continuously from the periphery to the center without any bumps, etc. So this is what the lens is all about. And if you see at the power map that is there, so you have spherical lenses which are there, which is this one. You have the Technis monofocal lens, and you have the Technis IOS. So they compensate for the asphericity. This does not compensate. This, both of them compensate the same way for the asphericity of the cornea. This is what it does, the central movement from the periphery to the center. It is, I would say, a mini EDOF lens, or whatever you wish to say. There is an intermediate range that comes about with this lens only because of the central change in the spherical aberration that is there, and this is what you have. So this is how you see, if you look at the on the model, you see that this is what is the IOS, and this is what is the single piece. So it provides improved intermediate vision without compromising on the distance vision. That is the main key thing. It does not compromise on the distance vision, and the distance vision is comparable to any good aspheric monofocal lens. It delivers photic phenomena profile which is similar to the aspheric monofocal, and tries to, because of the negative asphericity like in the Technis, it tries to reduce the spherical aberration to near zero. Now when you compare it to the intermediate vision, that means what you are looking at the intermediate, if you look at both these, you can see that there is a 1.1 line difference which is there in these particular cases. So this provides statistically significant improvement at 66 centimeters. That means that is your intermediate. If you are a tall person, that's pretty good for you. Maybe shorter people, there may be a little problem from that, but you are looking at somewhere around 2040 that you are looking at. Now we did a study, there was a lot of issue about the stability, because I am going on to the second part of the talk, which is the toric lens stability. So Technis was supposed to be slightly unstable as regards its position, as regards toricity. So the company responded and they brought about what is known as the Toric 2, which is, basically the version wherein the little thing that has been done is that the haptics have been frosted. So that, what is the frosting of the, you had smooth glistening, they could slide a little bit, but if you frost something, there is friction. And this friction actually causes the capsule to stick, and that is why they stay where they are. So this is squared and frosted appearance, that is what you have with this particular lens, which is again a single piece lens which is there. So what we did was we compared 70 eyes, 35 Technis eye hands, and that is the Toric 2 with 35 of the lens from another company. That is where they were said that this has the best stability which is there. Adult patients were used. So the irregular astigmatism, previous corneal surgery, etc., these are the same. So this was to compare the rotational stability, safety and visual outcome of the Technis IN's Toric 2 with the Clarion Toric. So when you are looking at the observations, the IHANS toric versus the Clarion toric, 2.1 degree was the rotation that we got versus the 2.9 degrees. So this is not statistically significant, but earlier the noise that was there is that you don't have stability in toric with the Technis lens, with the Technis 2, with the IHANS 2. This is no more relevant because it is as stable. In our study, it was found to be a little more stable. But when the real kick that came in was the uncorrected visual acuity at 3 months, when you're looking at these Snell's, there is no comparison. The distance visual acuity was comparable, but when you look at the intermediate and the near, you saw that the IHANS Toric 2 performed much better than the Clarion Toric which is there. The near ad requirement, according to, in our patients, averaged about 1.5 diopters. As I told you, in my pure C, it is 0.75 or something. So here it is between 1.25 to 1.75. In bilateral cases, it's slightly lower than 1.5 as compared to the other one, which is closer to about 2 diopters. So friends, at the end of the study or even otherwise, I don't ask the patient anything. The good thing that the company did was that this lens is not super highly priced as compared to a monofocal lens. It's only marginally higher. So I don't even discuss with the patient my go-to lens, or in our centers, the go-to lens is a monofocal plus from the IHANS variety, because we have had excellent distance visual outcomes. It has been a glistening free lens. There is nothing wrong with the material. The material is great, low PCO rate. And specifically when you're coming to the toric version of it, it has outstanding rotational stability, and lifestyle wise patients are virtually spectacle independent. So friends, this is what I have to say about this lens, which is my standard of care today for practice. Thank you very much for your kind attention. Thank you.
Thank you, Mahipal. May I request now Dr. Jeevan Tityal to come over and talk to us about role of monofocal plus for expanded patient groups. I think, again, Dr. Jeevan Tityal is one of the pioneers in cataract surgery and has led with distinction the RP Center for several years, and now is entering a new era of growth, and I'm sure he'll continue to leave his mark. Over to you, Dr. Tityal.
Thank you so much, Dr. Ramamurthy, and good afternoon, friends. I think we had a terrific condition IOLs, and we also have a significant confidence, experience of these IHANS lenses for so many years, no financial disclosure. And these points have been highlighted by both Dr. D. Ramamurthy and Dr. Mahipal Sachdev, the advantage of this monofocal plus lens, where we're looking for a functional vision for advantage of people who are undergoing surgeries, and looking into a profile lens, which Dr. Mahipal beautifully summarized, and this is what Dr. D. Ramamurthy talked about, the various literature on IHANS lenses. Effectively, this tells you that if you look at the defocus curve, this is Technis versus Techni IHANS. You can see nice defocus curve ranging from -0.5 to 1.5 diopters, and that gives you advantage of intermediate vision, which Dr. Mahipal was talking about. If you summarize the entire studies in the literature, almost 85% patient will achieve 20/25 vision intermediate, and 30 to 40% will have with a standard monofocal. See the difference between 30-40% to 85%, and better functional vision without the compromised quality. That is the idea of giving intraocular lenses to our patients. No visual photooptic phenomena which can be disturbing or disrupting to their function, and uncorrected near visual acuity is also better, almost 1 to 2 line better than a monofocal lenses for these patients. So therefore, if you see the last line, higher patient satisfaction, which we are looking for, with the spectacle independence most of the time for these lenses also. With the experience of eye-enhanced lens for so many patients now, we thought why not to look into a special situation, which normally we'll say if you shift from the conventional monofocal lens, they'll say don't do it, don't implant in the cases where it is compromised, like diabetic retinopathies, glaucoma patients, or patient who is going to have significant problems subsequently. So we have patients of diabetic disorder, glaucoma, post-refractive surgery, dense cataract where you can't actually assess the retinal macula in these patients. What about using these lenses to expand your patient experience with these lenses for future directions also? Ultimately, we are looking for a functional upgrade of patient after going surgeries. So these are few studies which are available on comorbidity features. This is one study where they've used eye-enhanced lens along with a vitrectomy in vitreous hemorrhage patients, and they showed that very good intermediate vision in these cases also. Other way around is you're looking for a glaucoma patients, it also does not decrease the contrast in these patients also. We designed this IIT investigator-initiated study with J&J. In last 6 months, we have recruited many patients, but our criteria was to have binocular surgery to be done within a month, and patients should have a diabetic retinopathy without any maculopathy or proliferative disorder, and bilateral phacoemulsification with eye-enhanced implantation are done in these cases. The study aimed for to look for visual outcomes of this enhanced monofocal lens in diabetic retinopathy patients. We looked for a visual acuity as a primary outcome, uncorrected distance, uncorrected intermediate and near vision, binocularity, and look for optical quality matrix, that is MTF, contrast sensitivity, color vision, stereo acuity for these patients, and also most importantly look for a patient satisfaction and look for a photic phenomena in these patients also. In result-wise, in these 24 eyes, you can see here almost 82% of cases achieved uncorrected intermediate vision at 66 centimeter or 20 and 40, and 36% achieved an 8 or better vision at 33. If you take this as a 40 centimeter, maybe this percentage will further increase. There's a wonderful results. All patients improved from the pre-surgery to post-surgery in terms of uncorrected acuities in all distances. The second important thing for a binocular surgery is to look for binocular function. And the best way to assess is a stereo acuity for near and distance for these patients. And we found that the stereo acuity for distance and stereo acuity for near were as good as monofocal lenses, or they are comparable to a standard age group patient as such. In terms of MTF, we look into MTF right from the from smaller range to a higher range. You could see better MTF in eye-enhanced lenses compared to pre-operative conditions. But in fact, if you look into a diabetic patient where you think contrast will be poorer, but these patients did pretty well in terms of increased MTF in these patients also. Contrast sensitivity, which is again one of the important criteria for all pseudophakic patients. We had a significant improvement in all special frequencies. Posterior values are within the sometimes even better than the normative data seen in individuals with the same age group, and excellent contrast sensitivity at lower frequencies also, which is supposed to be compromised in diabetic retinopathy patients. Visual quality indicators like Stultz ratio and higher order aberration, again there was significant improvement in both of them from pre to post surgery. And color vision wise, which is another important area to be assessed after a TECNIS design or as models where we look for improved contrast in these cases by not hampering the chromatic aberration for these patients also. If you look into values-wise, post-op color vision scores were within normal limits as age group, indicating that it preserves the chromatic aberration or discrimination from patient suffering from a diabetic retinopathy per se. I think this is one of the most important slide which came from our patients. You see here, almost 95% did not report any difficulty for near, intermediate, and distant vision tasks. Around 80% of cases were totally independent from the spectacles, which is a very high number. Only 20% of patients require a near addition, that too in reading of very fine prints. And if you look at other area also, the glare and halos were less than 6% of our patients. And this is to a direct questioning to them. If you ask them, they might say, yes, yes, I see. Otherwise, they don't complain at all. Therefore, high functional independence and low photic disturbance is the outcome for this study, and which goes with the IOL IOL per se also. So if we look into our interim results for these 24 eyes, uncorrected distant visual acuity, uncorrected near visual acuity improved by 4 to 5 lines from this pre to post, and equally for near vision also. And almost more than 82% of cases achieved good vision for intermediate and distance per se. Quality-wise, all these patients had a very nice visual quality, good stereo acuity for distance and near, good contrast sensitivity, preserved color vision, and minimal photic symptoms. That is what we are looking for with IHANS, good distance near vision, effective contrast transfer, color vision comparable to normal population, high spectacle independence, even for near, distance, and intermediate, and definitely delivers a strong functional outcome in these patients of diabetic retinopathy also. So we can rightly summarize, Technics IHANS IOLs offers a safe functional upgrade in diabetic retinopathy patients, which are normally we exclude from your routine indication for these lenses. Especially look into a contrast, chromatic aberration, color vision, they're all preserved in these patients, very well tolerated. These group of patients. We do have some glaucoma patients also enrolled in these studies, and with the results will come subsequently. Dr. Sridevi Nair, who is sitting here, going to continue this study for another 1 or 2 years. Thank you for kind listening.
Thank you so much, Dr. Tityal, for that very extensive study and reporting of the results. Basically, the POC was all about analysis of our initial experience. Well, this is a lens which has been, we are expecting the IHANS to take over for monofocal plus, and many practices have already done so. And the last 3 speakers essentially tried to justify whether this kind of confidence is rightly placed, and as of now it appears to be. We have overshot our time, but let's have a quick comment from all our colleagues, panelists sitting here, who are all experienced cataract surgeons, and I'm sure they all have significant experience with the IHANS. Over to you, Dr. Arup.
This lens became this is a mainstay of my cataract surgery. Whenever I almost, it replaced my monofocal practice. All the cases I implant. These IHANS, so far I implanted more than almost 5,000, if not more, IHANS and IHANS toric. So because now the IHANS is available in toric platform, the previous couple of years, first couple of years it is not available in that. So why the practice in implanting IHANS has a hindrance that time, but now it is no problem. And this is practically no glare, no halo, and definitely some advantage of intermediate vision.
I think point well taken. I mean, the best thing that they did about this lens is that they priced it right, in the sense that if it was significantly higher, the adoption rate would have been a challenge. Now it's very easy to convince our patients to go for it, and the advantage it accrues is also appreciable. Yes, Dr. Vineet.
So I just have one question. Mahipal sir and you, both of you have used both IHANS and POC. I did speak to you already about how would you compare the two, and where would you use which?
I think as far as IHANS is concerned, I never promise my patients spectacle independence. And I always, and I neither do I do much of mix and match or mini monovision. I tell them intermediate vision is what you're going to get with this. In case you want to do some serious reading, you may have to use readers.
glass.
An excellent quality of vision as far as distance is concerned, and a good intermediate vision, and readers if they're keen on reading. But what the POC brings, in my initial experience, and what other speakers have also said, is that, you know, especially once bilaterally implanted, they seem to be capable of taking care of even the reading requirement. Rupak?
Is there any specific comorbidity or ocular pathology where you wouldn't put eye-hands lens?
Frankly, wherever a monofocal can be placed, eye hands can be placed. That should be my.
Consider that
and
in a pediatric.
as was told, yes.
Any pediatric?
I don't see why not. Why not?
I think the standard of care is rising. Like we are actually approaching towards treating presbyopia. And the whole idea in the technology which is moving is that why ever use a monofocal when you have a monofocal plus. So now I believe the standard of care is going to be a monofocal plus itself, where we can enhance the scale from 0 to say about 4 or 5 in terms of the vision improvement from distance to intermediate and to near. And Pure C is a step ahead of eye hands, where you are actually able to reach that 9 out of 10 in scoring the spectacle independence.
Narang, your comment on eye hand should be shorter than that on POC.
Only one comment, that is, I have tried many other advanced monofocals, but with time, the intermediate vision deteriorates in other platforms, not with eye hands. It remains stable for a long, long time.
Thank you. I think we have overshot our time, and thanks a lot. This was a very interesting discussion on two lenses, I think, which have come to stay, which we'll be seeing and implanting in our professional lifetimes in the years to come, the POC and eye hands. Thank you, Johnson & Johnson, for getting this, putting this session together, and more importantly, giving these two lenses to us. I thank all my co-panelists, the speakers, as well as the audience who stayed back. Thank you. And my sincere apologies for overshooting our time.